All right, good morning, everyone. We're going to kick off this instructional session, Size Matters, Proper Design in Pediatric Manual Wheelchairs, with Lauren Rosen. She will introduce herself, and thank you for coming.
Good morning. I have to tell you, I'm completely blind. I can't see anything out there at all. The light is really bright. So feel free to surf the internet or do anything else if I'm not interesting and fun. I'm also bummed, as I was hoping they'd move a couch from the previous session over to here and I could lay on the couch the whole time and talk. That looked really comfy. So my name's Lauren Rosen. I'm a physical therapist in Tampa, Florida. My official job title is with our children's hospital, but I see children and adults for wheelchairs, and then I also run a 3D gait lab that analyzes how kids walk. I just officially hit my 20-year anniversary at my hospital this month. So yes, if the question is, did I start this when I was 10? Yes. Also, just a favor to ask, I've seen a lot of people taking a lot of photos during the presentations. I have permission for me to use the pictures of my kids, but I don't have permission for anybody else to have them. So I would ask that people would not take pictures of slides or videos of slides with kids on them. If you want my slides, I will happily send you a de-identified version that doesn't have the kids' faces in it. So just to let you know, one of these days, one of my kids is gonna see their picture someplace else and I'm gonna get in trouble, so. Okay, so the objectives. We're gonna talk about three, 2.5 areas of development that are affected by independent mobility. We're gonna talk about some growth patterns in kids with disabilities, and then some specifications about wheelchairs. So mobility and development. There's been a lot of research on mobility and development. We used to think that you had to do certain things to do other things, and there were ways you had to build on it. When we talk about depth perception, there's no wariness of depth till kids are mobile. They did some great studies where they took little babies, some who crawled and some who didn't crawl, and put little baby heart rate monitors on them and hung them off the side of a table. Not really sure how that made it past somebody's institutional review board, but okay. So they hung the babies off the table. The kids who crawled, heart rate sped up. The kids who didn't crawl were just looking around wondering when their next meal was. They did the same thing with kids with spina bifida a little bit later, some who crawled, some who didn't. Same thing happened. If you were mobile, you noticed the depth. If you were not mobile, you had no idea. Learned helplessness. This is one of the biggest things that when I learned this as a clinician, I said to myself, oh my gosh, I've ruined so many people's lives because I didn't know this. The most important thing is 4 years of age. It is firmly established by 4 years of age. There's long-term negative effects. The kids tend to be more passive, dependent. They don't do as well at school. They aren't motivated. Like, those are huge things. And all of that, it was because they couldn't do things for themselves. The big thing to understand about learned helplessness is that locomotion creates initiative. And for that locomotion to create initiative, it has to be functional and it has to be efficient. And I've heard multiple conversations this conference so far about like kids using K-walkers and how they are getting from point A to point B, and wow, isn't that awesome? But by the time they're there, they're exhausted. It takes them 15 minutes to get there, where if they had the right mobility device, it might take them 1 minute. So we've got to think about functional and efficient is the big thing with all of this. And, you know, again, we're looking to augment function. I have multiple conversations with my families, whether I'm looking at power chairs or manual chairs. I'm not saying little Susie's not gonna walk. She very well may be, but I need to get her mobile because of these problems. And I will actually give my families literature on learned helplessness if they fight me on it, so that they can understand that I'm not just making this stuff up. I mean, sometimes I am, but you know, this I'm not. So why size matters? There's a lot of injuries that occur very commonly in individuals who use wheelchairs. It's important for these kids to be mobile. We want them to function and, most importantly, play. And then, you know, the other thing that I think is super, super important is the cosmetics and the self-image of what they look like in these systems. Oops, wow. I was a little too excited there with that first flip. So common injuries. I think by now most people have looked at the research about ultralight manual wheelchairs and seen that the higher the forces and the higher the rate of the rise of the forces, the more risk there is of injury. The rate of carpal tunnel syndrome, shoulder, elbow, neck pain, rotator cuff tears, all of that increases with the time of use in a manual wheelchair. So we're starting these kids off at sometimes 11 months of age in a manual wheelchair, and they're gonna live their whole life in that. So we really need to be thinking about what these injuries are and doing everything we can to prevent them. With those common injuries, you know, once you start having pain can completely ruin your life, just pain in and of itself. Besides the fact that you have a lower quality of life, you don't wanna do as much. The loss of independence, for a lot of people, that also means going to a power chair, which is a huge change of life for them. So the better we can design this equipment for these kids who are going to be adults who use wheelchairs, the better chance we have of them not having these injuries. We did a little study at my hospital and a hospital in Toronto where we just looked at 16 kids. We had some kids with spinal cord injuries and some kids with cerebral palsy and some other injuries. And we just looked at their propulsion. And like we were using a smart wheel. So we were just looking at the kinetics of propulsion, so the forces involved with propulsion. And what we really found is if you look at this, what the graph does, I've been told possibly in the back you're not gonna be able to see my nifty laser pointer, but I think you can see the blue line. So blue line is what is considered adult normative propulsion. So all of those blue lines. So if you look, velocity, the kids with spinal cord injuries tended to be able to get pretty close to the velocity of the adults. The kids with cerebral palsy, muscular dystrophy, not so much. The average force that they had to put out was nowhere near adult, but the kids with cerebral palsy had to exert more force. Push frequency, the kids with cerebral palsy and muscular dystrophy had to push a lot more than the other kids and the adults. And then the stroke length. So the kids with cerebral palsy couldn't do as long of a stroke length. A lot of different reasons behind that. Could be spasticity, could be joint contractures, all those things. But you know, we're already setting them up. They don't have the same control as an adult who has a spinal cord injury who's using a wheelchair. So we need to be thinking about that as well as one of the causes that can cause the injuries down the road. So function. We need the kids to be able to do their activities of daily living. We need them to be able to go to school, to go to the mall, to go to the playground, to do sports, and as Jeannie mentioned this morning, misbehave. I love it when my kids misbehave. I love the stories of my kid getting in trouble. If my kids end up in timeout, I am happy as I can be, because that means they're a normal, regular kid. Briefly on positioning, as we start talking about just sizing of chairs and all of that as we go along, there has been research done about scoliosis. Everybody thinks if you work in pediatrics, we've got to prevent scoliosis because kids in wheelchairs get scoliosis. Okay, well, I'm here to tell you that those two lateral supports that you put onto that wheelchair are not going to stop that. They did a research study where they put kids in with neuromuscular scoliosis in TLSOs, which are super fun to put on, especially and wear in Florida in the middle of summer. And they kept them on them 24 hours a day. They literally only took the TLSO off for bathing. And those kids' scoliosis progressed at the same rate as kids who didn't have it, who didn't have the TLSO. So if a TLSO, which is the most supportive thing we can put on somebody, isn't gonna slow your scoliosis progression, those little things under your arms are not gonna do it either. Some of the kids need them, and you'll see some of my videos and pictures do have kids with laterals, so I'm not advocating for no laterals, if they need them for balance. But just putting stuff on a chair because you have CP, and everybody with CP gets this chair and it looks like this. Everybody with spina bifida has this chair and it looks like this. There's a lot of that happens out there, what I call diagnosis seating. That's not necessarily true. You shouldn't have that unless you need it. We're not gonna stop hip subluxation with a pommel. It's not gonna do it. Again, they may need the pommel so that we can keep the range of motion so mom can toilet and bathe and do the hygiene and all that kind of stuff. That's very important. But doing it to prevent hip subluxation, there is so much research that's out right now on the hips and surveillance programs and all of those things. We're not gonna stop that. I also hear a lot of, well, Susie needs that on the chair because they have to have that to get onto the school bus. Has anybody ever looked at the owner's manual for the wheelchairs that we provide? Anyone? Anyone? Okay, I suggest you do it, because even with the tie downs on the chair, every manufacturer out there has a thing on their chair that says don't ride in a vehicle in this wheelchair. Every single one of them. So again, putting stuff, we need to be advocating for these people taking these kids out of the wheelchairs and putting them into something else. Putting them into car seats. Some of these kids, especially with the manual chairs, can sit in a regular seat with a seatbelt. That's a safer place to ride in a bus. So anybody who tells me that I have to have a headrest because the child's going on the bus, I will fight them to the end of time, and I have not lost to a school bus driver yet. I've had to have a lot of fights, but I haven't lost yet. So if the kid needs a headrest to sit upright, then they need a headrest. That's great. And I want them to have the headrest. But if they don't need it and it's just adding stuff and weight to the chair, they don't need it. So function. So this is a little buddy of mine. This is Josh. This is one of the first times that I saw him. If there's anybody here from Kennedy Krieger, I can't see anybody, so I don't know. You may recognize him because he goes up every summer for camp or the 2-month hospital stay. Josh has transverse myelitis. He's also since been diagnosed with a lot of other problems, but at the time he was a C6-7 quad from transverse myelitis. So he is in a folding frame chair there with rigid positioning equipment on it, a headrest, a backpack. When we took him and put him onto a scale, he plus the backpack weighed over 76 pounds. 76 pounds. That kid weighs just over 20 pounds. So he's pushing a wheelchair that weighs over twice what he weighs. And then we're saying, go live your life. Go be active, go do things. Now this kid never stopped smiling, and I think he would have kept pushing, but he would have stopped very shortly because he then got diagnosed with a glucose problem. He's got diabetes and seizures now, and he can no longer push anything remotely heavy. But so we put him into an ultra-lightweight manual chair, put less in his backpack as you can see there. We got rid of the headrest. He did need lateral supports, so he got lateral supports on there. We also set up his chair a little bit better than that other one was set up, but he's much more functional in this chair. I unfortunately, hindsight's 20/20, I don't have video of him propelling the other chair, but again, you've got a 5-year-old who's a C6-7 quad, that's pretty good propulsion, that's pretty good speed he's getting. Even when he gets a little bit older, when we moved to his first titanium chair, he can move that and he doesn't even have to think about it. He's got even less stuff on that chair as he got older. He's now in his 3rd titanium chair and now has a smart drive also because he can't go long distances due to his fatigue. Play. I saw this quote and I thought this was nice. We learn more when we're playing. I think everybody knows that from this because you come home from this and you're like, what do I remember from this conference? Because I sat in a room all day like back when I was in school. And we don't remember things as well as we'd like to. That's why some people take nice notes. I always think I'm gonna remember it and then don't. But less repetitions to learn stuff if you do it with play. How awesome is that? But really the job of a kid is to play. Play is how we form our identity. And they did this great study where they looked at kids with disabilities and they looked at how they played. And they found that the kids played alone most of the time. They played with grown-ups more than they played with the other kids. And when they did play with other kids, they were in lower status role. So when you played school, you were always the student, not the teacher. You're always the baby, not the mommy. You know, that's how we figure out the roles we're gonna have in life. At some point in time, we all wanna be the mom, the dad. We all wanna be the teacher. Because we gotta learn, ooh, I like bossing people around. That's kind of fun. That's good, you know. Or, you know, I'm more comfortable with people telling me what I'm supposed to do. That's great too. But that's how we figure out who we are. They actually, in this research study, what they did was they actually talked to kids and they asked them, they watched them play and they asked them how they play. And this one little boy, it still breaks my heart, they said, you know, what do you like to do at school with your friends? Well, and this couldn't happen these days because that's just, you know, wrong, and I'll tell you that now because it's wrong and everything at schools. But they used to play war. And so everybody used to get a weapon, again, not anymore, not at school, and they would fight till everybody was dead. Boys. Girls are over there making things in the, you know, fake kitchen, and the boys are playing war and killing each other. But they asked him even more about how he played war and what war entailed, and he said, well, you know, everybody gets a weapon. And they said, well, what weapon do you usually get? He said, well, you know, most everybody gets a gun, but I only get a knife. So I'm usually the first one to die. So the kids at his school had figured out a way for him to participate in the game, but they knew that based on the kind of equipment he had, he couldn't follow them around and play on the playground and run behind trees and all that kind of stuff like the other kids. So he was always the first one to die. And he didn't like that. Like, he always wanted to get to have a gun. Again, not advocating guns in any way, shape, or form. But in the play water gun world, I want my kids to get to do that too. My kids should have every right to, again, I'm not saying this like I mean it, kill other kids in play, just like the other ones do. If everybody else gets to play that way, our kids in chairs should play that way. And so by setting up their equipment so they can do that, we're helping them to do that, and we're helping them to have the right kind of self-worth. Cosmetics. I am all about how my chairs look, because I think that matters. And they've actually done research where they they talked to kids in wheelchairs, and they talked about what was important to them. They wanted to have a good self-image in that chair. They wanted to have the highest function, so they wanted to be able to go wherever the other kids were going. They wanted to be able to interact with their peers properly. By the way, these are not my patients, so anybody wants to take a picture of the butts, you're more than welcome to. That's some random internet thing that I've seen 85 times, so I just thought that was good for cosmetics. But you know, what they found was if their chair didn't make them feel good about themselves and what they were able to do relative to their peers, that these kids had an increasing sense of isolation and a decreasing sense of self-worth. And a lot of these kids were chalking it up to the chair. So it's super important that we think about the cosmetics of our chairs. So, I don't know why that's doing that. Okay, so, you know, these are just some examples of kids who came into my office in what they were in. I feel like I see chair first when I look at these kids. Most of them are smiling. I try to, you know, make everybody look sad in the chairs that are bad and happy in the ones that are good. But, you know, these kids are smiling and they're enjoying their lives for the most part. But I see chair. I see lots and lots of chair. In my office, for the most part, I see kid. The first thing that I see in the chairs that I design is the kid. And then, oh, what a cute chair. Now, and yeah, I don't have anybody in here in one of the hot pink ones. Sometimes with the hot pink, when they're little, with the little girls, when they like that, sometimes you can't do anything but to see the chair first because, wow, that sucker's bright. I'm like, don't pick the pink. Please don't pick the pink. But again, having chairs that have less stuff on them, that are less medical looking, make them more approachable and seem more kid. then I've got a disability. So growth patterns. The reason why this is important is because of the way we tend to set up chairs, and we're gonna talk about chair setup in just a minute there. But we need to think about how kids with disabilities grow. They do not grow the same as their typically developing peers. They tend to be shorter, they tend to be lighter, they tend to have less muscle mass and fat stores. They have decreased bone density because they're not up and walking, which makes them weigh less as well. And in a lot of cases, in a lot of these kids, they tend to grow more in length than they do in width. Because especially with cerebral palsy, when you have spasticity, you're using a lot of energy all day long. And a lot of these kids may have some feeding problems as well, and so they're not eating as much as their other peers, plus they're using more energy just sitting there, so they tend to be skinnier. When you look at the growth patterns and you compare the growth pattern of kids with disabilities to kids who are typically developing, the rate of growth is much slower, and it's not stable. They're 5% shorter at 2 years of age, 10% shorter at 8 years of age. So we need to think about that, because I think a lot of times, especially when people are new to pediatrics, they're like, oh, I have a 5-year-old. I remember how much he grew between 2 and 5. Or, oh, I don't have kids, I have nephews, and I remember how my nephews grew. And so I need to, because this chair has to last 3 years, 5 years, depending on the payer source out there, I'm trying to make something that I know can last that long. And so I think we overestimate how much these kids are gonna grow. I think also in how we're designing some of these chairs, by making them so big and so heavy, I think we're making a lot of individuals overweight. I see a lot of teenagers who come to me for the first time who are in folding frame wheelchairs that they've been in since they first got in a wheelchair. It has every piece of positioning equipment known to man on it, whether they need it or not. The rear wheel position is so far behind them that they can barely push it. And they all come into my office 15, 16 years old, and they're all fat. I don't think that having a disability like spina bifida automatically makes you fat. I've got friends of mine who are Paralympic athletes who I swear their whole butt is the width of my thigh. So I know that that diagnosis doesn't make you fat. But I know that I see numerous individuals coming to my office with spina bifida and cerebral palsy who propel these folding frame chairs with every piece of positioning equipment known to man on them, and they come into my office as teens fat. And I think it's because the chair is heavy and it's hard to propel. And so if the choice is, I'm gonna go try to chase my friends around and it's exhausting, or I'm gonna sit on my couch and eat the Cheetos, I'm picking the couch and the Cheetos. I mean, personally, as myself, I probably would pick the couch and the Cheetos anyway, because I'm not exactly super skinny as it is, so I'm not judging. If you pick the couch and the Cheetos, totally okay. But I wanna give these kids every opportunity. And if we are trying to empower them from the very beginning to be as mobile as they possibly can be by designing their chairs properly, I'm hoping we're seeing less of this. I know, I have a running case study of a number of kids that I started at 11 months of age who are now 8 and 9 years of age who have been in more functional chairs. One of them you're gonna see in a few minutes, and none of my kids are fat. And I think it's because the wheelchair's been empowering the whole time. So, because this is only an hour course, I could only go with kind of the top 3 of the measurements that are important in kids, but they're the ones that I think we tend to do wrong the most. Seat width. Now, I will tell you all of these pictures and stuff of any of the things that we're gonna talk about, there's usually 3,000 things that I think are wrong with the picture on the left that's not just seat width. But look at that chair. First of all, you can't even see her. She actually became my patient because she was up on my floor seeing my orthopedic surgeon one day, and I saw her in the hallway and I said, I can't leave this. Please let me get you a new chair. I do stalk patients sometimes. You can't look at that and go, that's a good thing. But you see her over there on the side in the chair that fits her more properly, and it just looks so much better. So this is her, hopefully it's good, yeah. Nope, come on. So this is her propelling. Those are stickers in her mouth. We had to bribe her with stickers, and apparently we couldn't put the stickers down. We needed to keep them in our mouth while we propelled. The fun of pediatrics. But if you look at her propulsion in that chair, she's really abducting her arms. She's reaching really far to get to the wheels. She certainly can't get to the push rims. I mean, and a lot of our kids can't get to the hand rims. That's just how it is when you're that little. But yeah, okay, so now we're gonna finally put some of the stickers down. Let me speed her up just. Oh, it won't let me do it in here. But so that's my seizure-inducing hallway outside my office. So I apologize to anybody who's seizure friendly there, because, but you know, she can go pretty fast. She can do pretty well, but she's also got 1,000 pounds on her. And then you see her in the Ultralight pediatric chair, and you see her arms are in a much better position. She actually agreed to put the stickers down at this point in time. But she can turn quickly. I can't find the video currently of her that does it, but we asked her which one she liked better, and she said the purple chair. And we asked her why, and she said, because I'm faster, and it's easier. So, you know, even at that age, she can tell we've given her something that's better for her. Did she end up eventually with her, that's not her chair, that's my chair. She ended up with some lateral supports down the road because her scoliosis got pretty bad and she couldn't sit up and push. But she's just had her second spine surgery, so we're hoping to get past the need for the laterals. But, you know, I mean, even see with, you know, this kid Austin here, he had had his chair for 4.5 years. And it was still too wide. You can see air there. So I only wonder what this looked like 4.5 years ago when he got it. Now, I will tell you this chair on the right side there, a little too narrow. If you're sitting there going, that doesn't look so good. This is what happens when you've got an insurance company that won't let you get anything new no matter what you try. And you have a friend who has a wheelchair who was willing to donate. So one of my friends donated to him. But again, if you watch him push, if you watch him here, you see how abducted his shoulders are as he pushes down the hallway. And again, it was a great chair, it just wasn't set up for him. But so this is the new chair. Now see how nice his arm position is, and then watch what he's gonna do at the end of the hallway. He hips that chair. We didn't tell him about turning using your trunk and hipping. He just felt connected to the chair, and so he did it. So he was over the moon happy with this. He actually got into wheelchair racing shortly after this with a real racing chair and everything. But, you know, that much of a difference made a huge difference to him in how it felt to propel a chair and how he felt about himself. Because he had never been around other people in wheelchairs, and he somehow happened to come out to a race that we used to have in Tampa and saw all these guys in these beautiful, well-fitted chairs, because, you know, athletes are sometimes really picky about what they get and all that kind of stuff. And he was like, why does my chair fit like this? And I don't have an answer. You know, if sometimes I'll say, did your therapist not like you when they did your chair? Or the other one is, were you fat? I've had that conversation with a number of adults too. I'm like, did you lose 100 pounds since you got this? Or, no, that's just how the supplier said it was supposed to be. I was gonna grow into it. Okay. You're 30, but you're still gonna grow. Seat depth. So Obviously, this seat depth is too deep. If you see what he's doing as a result of this seat depth, he has posteriorly tilted his pelvis, slid down, and his arms are in a terrible position there. And just to make it worse, when you see it, the therapist and supplier who designed this pulled the foot plate out even farther so we could, really pull on his hamstrings even more and really posteriorly tilt him. So this is him propelling. He actually was not referred to my office for a wheelchair. He was referred to my office for a gait analysis, but the wheelchair killed me. So I had to look at it and play with it and everything. But he just doesn't sit in a good position, and he can only access the very, very front of that wheel because he's so sloped and rounded. So again, you can't grow into seat depth without compromising their position. Center of gravity. So this gentleman came into my office looking for a new chair. So this is what he was in. You can see how far behind his hand that axle position is. And again, this is power assist. We put him into just a trial chair that happened to be sitting in my office where the center of gravity was perfect and his propulsion improved dramatically. So this actually is backwards. It has him in the trial chair first and his chair second. But again, we've got somebody who's got a power assist system who can propel better without it. And it's not really the chair. I won't say that that chair did it. It's the center of gravity on that chair is in a much better position for him. And he can be much more active. So, with the power assist, he just pushes it and lets it start, but he can't push nicely. Again, he can only access that front part of that tire and hand rim. Another friend of mine who came in, again, with the chair that the center of gravity was not so good. He did have an unexpected growth spurt between these two and lost like 35 pounds. When we went to deliver his chair, I'm like, you should have told me, we could have made it smaller. But there were some other tweaks that ended up being made. But if you see him, again, that kind of what I call wussy pushing. He can only get to that much of the rim because he can't reach back. He slowly but surely gets this one after a little bit of time, but he's always had the wheel so far back that he's not used to being able to access the whole thing. So I got two kids to show you. Because, really, Pediatric is all about adorable children. So Charlie, when I first met him, was 11 months old. Just cute as a button there, with spina bifida. This is Charlie, the first time he was ever in my office trying a manual chair. I don't have the sound on because there's high-pitched squealing from his mother. So excited that he moves it when he starts. Yeah, Dad pulled out his cell phone, and the cell phone was a motivation to move somewhere. But again, he's 11 months old. People are like, oh, you can't put somebody that young. They need power, or they need to just be in a medical stroller. There's no reason why he can't have independence. But so he gets Dad's gets Dad's phone. But, oops. So this is Charlie when he actually got his real chair. Fits him pretty decently there. Again, he's not going to get to the hand rim. His arms are just so short that I'm not looking for hand rim yet. But he was so excited when he got in his chair and he got to get into the elevator by himself. He even, the day he got this chair, they went to the mall afterwards so he could play around, and it actually happened to be the same weekend as that race we used to sponsor in Tampa. And there were a bunch of athletes at the mall, and he went up to some of the top wheelchair racers in the world and challenged them to a race. So they all came that night there was a reception that night, and they're all like, I met your friend Charlie, But again, he's had independence from very, very little. So obviously kids get bigger. So he is larger now. He moved on to a new chair. He's had surgeries on his feet there on the side. And we're actually getting ready to look at him as soon as his mom can figure out a half day off of work for a new chair again, because he's outgrowing this one. But Charlie, because he's had mobility from very, very young, and he's had functional mobility, he has always been super independent. One of the things that always kills me is usually when you see pictures of kids in wheelchairs with their class, where are they? Are they in the center? No. They're usually like off to the side. Sometimes there's grandstands and they're like still off to the side. He's right in the middle of everything. Because he's just a kid and he doesn't see any difference to himself and these other kids. He does sled hockey. That was him during his first race, stopping in the middle of his first race to wave at his parents. Because that's what you do at that age. He also just went a week ago we had a WCMX event, and he's trying WCMX, and he just thinks this is the coolest thing ever. His mom, not so happy, but she wants whatever's best for Charlie. And so again, right now, of course, he's in just his regular chair, and if he were to really do WCMX, he'd need a real chair for that, because he'll tear this sucker to shreds if he actually does a bunch of real stuff with it. But, again, this was his first experience. This kid's not afraid of anything because he knows he can do anything in that chair. And he's known it since he was 11 months of age. I think it's pretty awesome. So my other kid, this is Theo. That's Theo's adoptive mom. That's Theo's half-sister. Theo has 4 other half-siblings in the area and 2 others that have left the area that were closed adoptions, so we don't know the other 2, but we know all 4 of his half-siblings. So Theo has been complicated since day one. He's got hypopituitarism. They finally figured out the actual cause of everything that's going on with him, which is a FOXA2 gene mutation. He's one of a very few kids in the world who have this, so if you're really excited, you can go Google it, because I won't tell you all the things, but it causes diabetes, it causes the hypopituitarism. He's got a G-tube, and due to an unfortunate surgery, he's got an ostomy. Something happened during a surgery that didn't go as well as they planned, and so he's got an ostomy that supposedly, hopefully in the next 2 years, is going to get reversed. So he's got a whole lot of stuff going on around him. Now, when we first met Theo, he was 11 months old. He was dependent for all of his mobility. He had no sitting balance. He babbled a little bit. So he got a medical stroller because we had nothing moving at that point in time. His sister's just kissing all over him on that one. But his mother said I could use any picture that I wanted as long as I used the Mike and Sully. That was not Thanksgiving, that was Halloween 2 years ago. It was pretty awesome. He was hospitalized at the time, so they had their costumes on for our Halloween party at the hospital. But so, he really wasn't capable of doing much at that point in time. But he wasn't in therapy, he wasn't doing anything. Well, he got therapy, and he blossomed. He wanted to move. He can kind of scoot on his butt in this weird way. He's got one leg that's a little wonky to doing stuff, and so crawling has been very hard for him. He's now actually doing some walking. When he'll hold on to it, he uses a walker. He's down to 2 hands. They're trying to go to 1 right now. But so we first wanted to try some mobility with him. So for those of you who've seen it before, we put him in my little Go Baby Go car. And he had super fun. And his parents went out and bought him a Mercedes, because, you know, you have to go top of the line. Of course, if you see how they designed that, he can't actually operate it. He can't reach there. They actually that's actually his medical stroller seating system that they put into the Mercedes. The only way he could operate it was he could actually do the remote for it. But we decided that that was also not functional mobility for him. So we put him in a manual chair in my office. This was just one day his mother just said, can we just try it? They were up for therapy, and I'm like, all right, fine. So we put him in a chair, and darn it all if he didn't roll himself. When we first met him, we were talking about power, because he was so low level. But we started looking at this, and then same day we took him over to therapy, and everybody at therapy freaked out that he was actually moving himself, because he hadn't started to crawl yet over in therapy. But I mean, seriously, look at that face. He's got one of those faces that you just want to, like, I'm like, do you want my car? Here, what do you need? I will do anything for you. Again, just reminding, because I think I'm seeing out there, even though I can't see, that people are videotaping. And if you show that to anybody else, I can lose my job. So I just ask that you please don't videotape and do that. So Theo had a problem initially. He wouldn't turn. He couldn't figure out how to turn. Well, Theo likes the ladies. And he is very, very determined for women to like him. So he was out at a rodeo, because his sister shows stuff, and I don't know a lot about all that stuff. But he was trying to get to the woman on the poster. He wanted to get to her, but he couldn't figure it out, because he wanted to hug her, and he couldn't get directly in front of her. And so he finally, if you see, that's how he learned to turn. And now he's gone head on into the lady and can hug her. So, you know, whenever you hear any of these talks about mobility and the right motivation, my kid needed a woman. We swear I didn't have it on video, but it's the first time that we put him in that manual chair, that first day, when he went out of my office, there was a woman checking into a doctor's office outside of my office, and I swear he tried to go like underneath her so she'd end up in his lap. But he's the kind of kid that you literally have to stop and admire. Like, he will stop you if you don't stop and acknowledge him, because he knows how adorably cute that he is. You know, but again, he turns 3 next month, but he's been all over the place. I love these little gloves. And the glasses, really. He looks like the grandpa from Up. He does, he really does when he has his glasses on. But he's gotten to show sheep, because that's what they do in their family. I think that's a sheep, maybe a goat, I don't know. I should really learn my farm animals. I live in Florida, and I grew up in Tennessee. But they went to Disney, he pushed all over Disney. You know, this kid's gone everywhere that he wants to go and is doing everything that he wants to do. And his mom likes to point out, you can't totally see it, she couldn't get a good picture of him in it, but the little onesie that she found for him says, rolls like a Royce. And she was so proud of herself that she found rolls like a Royce. But, you know, again, this is all about enabling. Like, this kid's doing everything he wants to do and everything he's supposed to do at that age. Does he get in trouble all the time? Absolutely. His favorite thing to do when he comes into my office is start rummaging through my drawers. So far, I have lost a thumb drive that we don't know. We think maybe he stuck it in his chair and it disappeared somewhere. He's taken tools. I've lost a few things because I wasn't paying enough attention, and he just pockets stuff. But again, that's what kids do. And most of the stuff he's stolen, they've brought back. Oh, he has your little mini skateboard. Oh, okay, thank you. I was looking for that yesterday. But so, you know, again, he does what he wants to do. So chair prescription, thinking about these kids. We want to go as lightweight as possible, both for function and for injury protection. We want those adjustable axles so we can get them as far forward as we possibly can and get that height right as much as we can, narrow as possible. Remember, all these pediatric chairs have growth either in them or growth programs. They all have a way to be made larger. Don't think that your kids are all going to suddenly all get fat and outgrow the growth on those chairs. I usually go about an inch wider than my kid, and I will tell you again, I've been doing this for 20 years, and I think I've had one kid who hit a weird growth spurt. It was mostly because of some medications that he had that we didn't anticipate. I've had one kid that suppliers had to change out the chair, that they didn't make the 5 years. And that was with 1 inch extra of hip width. Spina bifida, CP, muscular dystrophy, you name the diagnosis, I've done it. 1 chair in 20 years. Appropriate necessary support, again, please don't diagnose a seat. Oh, everybody with CP needs laterals. Everybody with spina bifida needs a headrest. Because why? Just because everybody saw it before? And cute. Cute's the key. Cute lets these kids live their lives. It makes them more approachable to other kids and to other grown-ups, and it makes it more fun, and it makes them feel better about themselves. And doing it young makes that chair enabling all along versus just the way that I get from point A to point B. Because in some of those larger chairs with a lot of stuff, you listen to those kids talk and they do not talk highly of their chairs. Yeah, you know, it gets me to school, it gets me here, but the kids who are in functional chairs, oh, I went down this curb and then this ramp, and the chairs are more enabling to them. So we have made it, I did pretty good, 12 minutes. So does anybody have any questions? We do have a roving microphone that people can use. Otherwise, since I can't see anything, if anybody raises a hand, I think there's people out there, I don't know. But if any of you have questions, feel free to shout them out. I just have to say them again so that we get it for the recording. Oh, I think I see the microphone moving.
Hi.
Yes.
So, quick question. How do you set or decide what is the right slope for someone? I heard you said you gotta choose the right slope. So, how do you determine the right slope for someone, depending on what parameters?
Seat slope, dump, there's all sorts of different words for it, but seat slope is the professional sounding word. For seat slope, we usually go about 2 inches on most kids. If they're higher injuries, sometimes we'll go a little bit more to give them more trunk. I can't tell you how many kids come into my office with no seat slope on their chairs, and they're all falling forward out of their chairs. Like, if you think about office chairs that we sit in, you think about your cars, all of those things, they all have some seat slope in them to hold you in them. So, you know, usually for most people, what I found is 2 inches seems to be that comfortable amount. And then depending if I need a little bit more support, then I'll change that.
My question is about the seat to floor height and about the approach to the rear wheels. So for the seat to floor height, you know, the kids are in preschool, and then they go home and they need to have access to different table heights and for transfers and so on. I feel like a lot of times our vendors recommend setting them up for more of an adult table height. So my question is, what do you recommend for that? And also, how far above the rear wheel, like which of the right elbow angle be so that they have the best access to the rear wheel?
So, you know, for seat to floor height, I like to keep the younger kids closer to the floor. Like, you know, both of those kids started out in a 20-inch rear wheel, because for most kids, most of their lives, if they're gonna go to preschool, they're gonna go out and do stuff, a lot of their lives is gonna be getting to the floor. And if you think about the preschool tables that they have, that's at that preschool table height, so that they can be with their friends. Yes, is it a pain when they go to a restaurant? Yeah, but a 2-year-old is still going to need like a high chair at a restaurant anyway, so I'd rather keep them at the same height with their peers initially, and then as they get older and they've grown, then that's when we're going more to the 22, the 24-inch wheel and raising them up higher. I'm still looking, when I'm looking at seat sitting height, rear seating height, I'm still looking at about that 120-degree bend. I don't want much more than that, because again, if you're up here, you can't push productively. If you're here, which I see a lot too, you can't push. So the hardest group of clients I find for seating in manual chairs are teenagers with spina bifida, because they have the shorter trunks in most cases and those super long arms. And so if you set it up based on their trunk, usually they're pushing like this. We have a lot of individuals with spina bifida who we actually put back to a 20 or 22-inch rear wheel so that they have a smoother push stroke. And they feel more, and they've all come back and said, they all look at it and go, that just looks stupid. Because it does. A 20-inch wheel on a teenager really doesn't look so great initially, but the functionality of it, they love it. I think I saw the microphone. Yes.
Yeah, that's really loud. So for some of those kiddos that you were changing their chair, they seemed pretty young to meet. I'm from Ohio. Ohio is a 5-year state. Were you able to justify to insurance that their wheelchair was set up improperly? Or how did you get around funding to get these young people new chairs?
So in some of those cases, if you noticed, like on the cosmetic slide, the one where I showed you the ones with all the kids with all the positioning equipment, and then I showed you a different group of kids, if you didn't notice, those were 4 different kids. There are a lot of times where I'm stuck and I just have to modify what they have right then. So I'll just start taking stuff off of the chair, taking the headrest off, putting a lighter weight back on there, getting rid of the pommel when they have no adduction, moving the wheel position to a better place. So in a lot of cases, if I'm nowhere near that 5 years, then I'm stuck modifying what they have. So I'm not always able to just automatically wave my finger and get everybody what they want. That'd be the magic wand from the earlier talk there. So in a lot of cases, I'm stuck with what I have. And I just try to make it as functional as possible, because the sooner I can get them into the functional chair, the sooner I can get them more active. It's very hard to get those kids who are 16, 17 years old, who've had those big heavy chairs with the wheels so far back. It's hard to get them active in life. We put them into the better chairs, we put them into the lighter weight chairs, and we say, there's this sports program, there's this, go do this, and they still have adopted a sedentary lifestyle. So it's modifying those chairs. I'm not saying that a folding frame wheelchair is a bad frame, depending on the reason. I will tell you that a lot of my chairs that I see come into my office that are folding frame have so much equipment on them that nobody folds them, because it takes you an hour to get the back off and the seat pan off and this and that, and it's too heavy. So most of my families who have those folding frame chairs with tons of stuff on them don't actually fold them. So the benefit to a folding frame chair for the parent doesn't actually turn into a benefit. So I just try to make it as functional and as lightweight as possible for the interim till I can get them. And I show them, because I have a whole wheelchair parking lot in my office, I show them, when I can get you a new chair, this is what we're going to. And I've had a couple of families who were so excited by the looks of the rigid frame chairs, that they fundraised and got their own before the 5 years was up, because they didn't want to stay in that once they knew that the other ones existed.
Have you had any success with convincing insurance that a new chair will be preventative for the injuries or further developmental delay, or?
If something is so far off that my suppliers and I don't feel like we can adapt it to make it functional for the next 2 years or whatever it is till you're done, then yes. The problem is, again, it depends on who the funding source is. In a lot of cases, they've changed the rule now, but in Florida, what was happening was if you changed chairs in the middle and you were able to justify it, they depreciated the cost of the frame that the kid was in, and then they took that off of what they were going to pay the supplier. So for a lot of the suppliers, they weren't able to do it because it was a huge losing proposition. I do have one supplier in my area that has a large set of loaner equipment, and so sometimes they will swap out a frame for me. So it's an apples to apples. They already had the frame sitting there, so we'll put them into a lightweight frame, and I'm able to do it that way, but that's the exception rather than the rule. But yes, we have been successful, but again, sometimes we aren't able to actually go through with it because of the amount that the supplier would get reimbursed. I sort of see a hand.
That's me. Hi.
Hi.
Have you dealt with late-stage ambulation muscle disease patients, like Duchenne's?
Yes.
And what are you looking at for their manual type chair?
Well, usually if I'm getting like really late stage, if I'm getting like a kid with Duchenne who's not on one of the new medical trials, which are just astounding to me, who is like 12, we're going power.
Well, yes, they're also going to get a power, but typically with us, they're also getting a manual chair.
Oh, goodness, no. See, okay, so my state is joyous, and we have a couple of payer sources that will occasionally pay for a backup chair, but in most cases, I can't get two. But for those individuals where I can have two, I'm still shooting for the lightest weight that I can get. For a lot of those kids, I am having to put some positioning on them just because they can't hold the trunk up. You know, so I'm really having to give them some lateral supports, all of that kind of stuff at that point in time. But at 12, I prioritize the power because that's going to be more long-term and more functional in more environments for them. I only had one mom who yelled at me when I tried to do that. It's the closest I've gotten to getting hit. Apparently the kid didn't know he had muscular dystrophy. He was 13. I said power and she just about hit me. Are there any other? I can't see. This really is like the brightest light you've ever seen. It's good for me though, because I'm just assuming everyone's smiling and laughing the whole time. All right, so is that a question?
We do have a question, yes. Hold
okay. Like, I saw the microphone handed to somebody, but I can't see what it was or who it was.
Do you use the term folding and non-folding, or have you changed your terms? I feel like when I talk with a family and we say that this is a non-folding chair, even when I follow up and show them how it does fold, that term non-folding sometimes gets stuck. So I don't even like to use the term, but...
I've never used the term non-folding.
Okay.
I've used folding and rigid.
Okay.
And that's one of the very first things when I put them into the rigid frame chair, that I show them how it folds. You know, because again, especially if I've got a kid who's gonna have any kind of back support on there besides upholstery, I'm showing them, hey, if I've just got like some kind of a basic rigid back on there, the back will just fold right down, it'll lock, you pop those wheels off and it's in the trunk. If I got you a folding frame chair, you'd have to take the back off. If, you know, a lot of those pediatric folding frame chairs, you have to have a seat pan. A lot of them don't have upholstery on the bottom, so you got to take the seat pan off. When we talk about the steps that are involved in folding a folding frame chair, my families pick rigid. I will tell you that I have my families, they don't understand until they understand why coming to a clinic makes a difference. And so I've had a number of them who did their chairs with me, but then went for their next chair, and their practicing therapist that they see, their treating therapist every day, said, oh, I can do the wheelchair with this random supplier guy. And the way that he explains it, they're like, oh, this is great. This is gonna fold, it's gonna be so fast and easy. And then they come back to my office 6 months later going, what did I do? This is terrible. I've never had anybody who had a rigid frame chair who happily was with a folding frame chair once they got it. So I just show them what it is. And I agree, I would never use the word non-folding, because that already puts an idea into their head that I don't want them to have. Because that rigid frame folds, it just folds a different way, is how we've always framed it.
Thank you.
I also tell them that, and I do, I've worked with wheelchair sports for over 20 years. So I've got lots of friends who are adults and not just the ones who have the butt the size of my thigh here. I've got larger friends, and I can get their frames in the back of my little 4-door car. So, I explain to them, because they're like, is that going to, yes, it will fit in any trunk on the earth. Those kinds of chairs will fit in any of those trunks. So, we have that conversation that I've done this in the real world with friends of mine with much larger chairs, and it works. So I am speaking from personal experience. The only time I've ever had a car that it was a different chair, but the chair didn't fit, and it was because the family had apparently one of those huge bass speakers in the back of their car, and it took up like half the trunk and like half the back seat, and they were like, well, we can't fit it. And I finally was like, well, this is what your daughter needs, so you're gonna have to decide what's more important to you, your daughter or a really good bass beat. I can't make those choices for you, but this is what she needs. And so medically, that's what she's getting, so you figure it out.
Thank you very much, Lauren.
Certainly. Thank you very much, everybody.